This is a Defocus Media production.
Audio Jungle.
What's up, everyone? It's your favorite optometrist, Dr. Darryl Glover.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus. What's up, everyone? It's your favorite optometrist, Dr. Darryl Glover. Happy Wednesday, happy hump day. I hope everyone's had an incredible week so far. Today, I'm super excited because I get to hang out with a panel full of all-stars, a panel full of eye care experts. And tonight, we have an amazing topic for our grand rounds. And I'm not going to share anything. I'm going to let my team here express everything that we're going to get into for the evening. But before we get started, I want to thank our partners over at Johnson & Johnson Vision for always being there for the eye care industry, for always figuring out what the students need. We are truly bridging the gap when it comes to students, making sure that they have everything that they need to be successful when they become optometrists, and also for new graduates as well. Friends and family, I'd like to welcome an amazing panel of colleagues, Dana Devito, who's a future optometrist representing IU, Dr. Susan Gromacki, who's an all-star, who's a living legend, has done so much, and her background is just amazing. And of course, we have the lovely Dr. Erin Rueff, who has done an incredible job with hosting these events, but making a big impact when it comes to anything eye care related. Welcome, welcome, and welcome. How's everyone doing this evening?
Great. Thanks.
Thanks for having us, Darryl.
Awesome. Well, before we get started, I want everyone to share their background. But before we get started, I want to start with Dana. For those that may not know out there, Dana is my mentee. And I've known Dana for a couple of years. And I've just had the blessing to be able to, an honor to just really watch her grow. I remember our first meeting, we were talking about networking and putting ourselves out there. And she looked at me like I was crazy. And she said, you know what? I'm going to do it. I'm going to do it. I'm going to do it, Dr. Glover. I'm going to do it. And she did it. And she has truly made an impact in eye care. She's truly one of the leaders in eye care. And I cannot wait to see what she's going to do down the road. But Dana, if you don't mind starting off, just maybe giving your background, maybe even sharing how or why you got in optometry. And then we'll go to Dr. Gromacki and then also Dr. Rueff. And then we'll get this party started this evening.
Great. Thank you for that warm introduction, Dr. Glover. It's an honor to be here. So I'm from Michigan, Kalamazoo, Michigan. I took 2 gap years before optometry school, did a little bit of real estate in New York, wanted to pursue medicine, and I figured the best way to combine those 2 subjects was with optometry, doing medicine and business. That kind of led me here. I'm currently a 4th year at Indiana University School of Optometry, and I'm at my 3rd rotation here in Bloomington. So it's great so far.
Awesome. How about you, Doc?
Well, Dr. Glover, I've been in practice now for 29 years, if you can believe it. I graduated from Notre Dame undergrad and then Ohio State for my OD and also my Master's of Science in Physiological Optics, which I think Dr. Rueff has completed as well.
Yeah.
During my master's coursework, I specialized in cornea and contact lenses, and I wrote my master's thesis on keratoconus. So over 230 pages on keratoconus with Joe Barr as my advisor. Many of you might know that name. He's one of the leading optometrists in the world, and it was great to learn from him. And then basically did a VA residency and was in academic medicine for, I guess, a total of 8 years, including my residency. And then met my husband. Unbeknownst to me, I followed him around the country a bit for his job. And now we've settled in Maryland for 11 years where I work in private practice.
Fantastic. Thank you so much for that great introduction. And thank you for all that you've done for eye care as well. Dr. Rueff, if you don't mind sharing, I know we all know you, but some folks might be their first time tuning in. If you don't mind your background and all the amazing things that you've done in eye care as well.
Yeah, like Dr. Gromacki, I am a Buckeye. So I did my optometry training at Ohio State, and then I did the similar program. It's called the Advanced Practice Fellowship in Cornea and Contact Lens, which, is a 2-year program where you basically have a residency, but also get your master's degree in vision science. And so, I did research like Dr. Gromacki and then stayed at Ohio State for several years and taught and worked on my PhD in vision science, where I did a lot of research on contact lens discomfort and visual issues that influence our satisfaction with contact lenses. I'm at the Southern California College of Optometry now. I'm the chief of the contact lens service there, and I teach in the contact lens curriculum and do a whole bunch of other stuff, including this. So I'm happy to be here tonight and dive into a new case.
I love it. And again, thank you to everyone that's on the panel. Thank you to everyone that's tuning in. Those that are locked in, be sure to share where you're at, what school you represent. We'll love to know where everyone's representing this evening. But we got a lot of star power, a lot of brain power, a lot of knowledge. And we're going to drop some knowledge on everyone that's tuning in this evening. So what we're going to do is get this party started. We're going to pull up this slideshow presentation. Myself and Dr. Gromacki is going to drop off, and we're going to let you two take the lead and have some fun. And then we'll circle back and give some expertise opinion about everything.
All right. Sounds good. You ready to go, Dana?
I am ready.
Okay, cool. Well, I've got some slides here, but I want this to just be like a conversation, like we were sitting in the consultation room in clinic. So again, just kind of informal, talking about how we can best serve our patients. So first, we want to thank our sponsors, Johnson & Johnson Vision, for sponsoring us tonight and helping make this happen so we can reach as many students as possible. All right. Here is the case for tonight. So this is what we're going to talk about tonight is one of my favorite topics to talk about in contact lenses. So I'm excited to dive in. Our patient tonight is a 45-year-old female graphic designer who's complaining of eye strain and kind of variable vision at the end of the day in both eyes. She says that her eyes get tired and her vision kind of comes in and out with blurriness and just kind of uncomfortable vision, especially, she's looking at her computer and stuff at the end of the day. She's currently wearing single vision, spherical, daily disposable contact lenses. And besides those symptoms she just mentioned, is pretty happy with them, has always had pretty good comfort and success with them. Here's kind of her pertinent clinical data. So some things to note here. She's wearing -2 in both eyes in her current contact lenses, seeing pretty well at distance, could stand to see a little better at near. And when we do our manifest refraction, we see that she's not quite -2, more like a -150 and -175 in each eye. The lenses fit well. Her anterior and posterior segment health is unremarkable, nothing really to speak of there. So I guess based on what I told you right there, what are some things that kind of stand out to you and kind of make you say, we need to address this for this patient?
I think the first thing that stands out is that she is over-minused by 0.50 diopters in each eye. Also important to note her age. She's an emerging presbyope. She's also doing a lot of near work. She has really high near demand throughout her job and performing her job. I think those are the three main things that are standing out to me.
Yeah, definitely. It's really common for myopes at this stage in life to kind of, they'll almost feel like their prescription got better when they come and see you. And it's probably not that their myopia improved, but that they probably have been just over-minused in their pre-presbyopic life. So that's really common for patients at this stage in life. So yeah, just getting her a better distance prescription would probably help some of her symptoms. But yeah, she's got a lot going on besides just the overcorrection. She is an early emerging presbyope. And yeah, she has high near demands. Honestly, most of our patients these days have really high near demands. We're all looking at screens all day long and, dealing with intermediate and near demands. So knowing all of that, what do you think her best options are, as far as contact lens correction that we could move forward with?
I mean, with contact lenses, we pretty much have like the monovision versus multifocal option. And I think especially with her, getting her started as early as possible is probably one of our better ideas. But I think mostly we tend to go toward those two options of contact lens correction for our emerging.
Yeah. So I'm glad you jumped right into a presbyopic option. I think you wouldn't be wrong to maybe say, let's try a single vision lens in her correct prescription. Because like I said in the previous slide, that certainly would help her. It wouldn't hurt things. It would certainly make things better. But yeah, I do think the best first step for her is actually to do a presbyopic lens. Sometimes people hesitate to do a presbyopic lens or presbyopic design this early in life because, you can get good near vision with a single vision lens. But I would argue that, starting a presbyopic contact lens modality as soon as presbyopia hits, or even maybe a little bit before the near blur comes on, helps a patient really ease into that modality so they don't get sort of negative symptoms with single vision lenses. So yeah, our question kind of is monovision or multifocal with this patient. And because she's an early presbyope, again, you wouldn't be wrong maybe to say, well, let's just try monovision because she doesn't have much of a near ad. She doesn't have, I guess I should mention on the previous slide, in case you don't have video and just listening audio, she did have about a +1 ad that improved her near vision. And so you could argue that, monovision could do well with her because she's just got a little bitty ad. And so it wouldn't make that much of a discrepancy. But what do you know about, and maybe I should also clarify in case maybe you don't know what monovision is. Monovision is, or somebody listening doesn't know what monovision is. Monovision is when we correct one eye for distance and one eye for near, compared to a multifocal design, which is when the lens has optics that kind of allows you to see all distances or a range of distances at the same time. How might we decide between monovision or multifocals, or what are sort of maybe the pros and cons of a monovision versus a multifocal option?
Yeah, I feel like sometimes this comes down to like practitioner and what they're most comfortable with. Speaking more like on a factual level though, I think monovision, and as a student, was a little bit easier for me to understand, honestly, because it's more math-based. You do distance prescription, you determine the ad needed, and you do a little math to determine, and you determine eye dominance, and then which one you're going to do distance, which one is for near. The big downside of monovision is that you kind of lose that intermediate zone. So you have your distance and near, and the intermediate is lost. With our multifocals, again, as a student, they were very intimidating to get into and look at the fitting sets and determine. There's so many out there. And then the pros though of multifocal is that you get like distance, intermediate, and near, and you also get stereopsis at all distances as well. So
yeah, that was like an excellent overview. Very good. There's a lot of like pros and cons to consider. I love what you said about monovision, that like as the clinician, it almost like feels better because you can get that like crispy clear distance vision and the crispy clear near vision. And so like in the exam lane, monovision just like feels better in your gut, right? Like it just makes you feel more confident that you're really serving the patient. And that a multifocal can oftentimes feel like a little more of like an unknown, like it can feel a little uneasy, like the patient may not be super adapted at first and not be super confident in it, which can make you not feel confident in it. So let's talk a little bit more about that. Those were such good kind of observations. So kind of exactly what you said, there's pros and cons to both options. For monovision, we really do get that precise distance and near vision, with the downside being we don't get the full range of vision. So that intermediate might suffer, or another kind of distance in the middle might suffer. Also lose stereopsis with monovision. But again, a lot of doctors really lean on monovision, especially for an early presbyope, because again, you can get that nice crisp vision. It's very satisfying in office. And you assume that that is what the best option for your patient because they're getting great vision. As far as multifocals go, just like you said, you really get that potential for a full range of vision with multifocals. I kind of think of comparing monovision and multifocals to comparing like a flat top bifocal to a PAL. So instead of, again, you have the potential to get the full range of vision, and some designs are better than others at getting you there, right? Again, the multifocal is going to allow us to maintain stereopsis. Technology and optical designs with multifocals is getting better and better I feel like every 6 months or so, we get a new design or a new toy to play with. But definitely in the past, multifocals kind of got a bad rap for kind of just having overall degraded vision at all distances, and maybe not having the best maybe contrast sensitivity or inducing glare and halos in patients. But a lot of those disadvantages that come with multifocals, or that we as practitioners assume come with multifocals, are really just preconceptions or thoughts about the lenses that are sort of left over from older designs. Monovision as our best option is really a concept that's left over from a time when our multifocal optics weren't that great and when we didn't have good parameters available for our patients. So we were limited in powers and modalities. But it's 2022. And we have really great options available to us now with multifocals. And what's really interesting is that there's been some studies in the last few years that have showed that patients actually prefer multifocal correction to monovision. So even if us type A clinicians really want that, satisfaction with the monovision acuity in office, our patients actually are going to prefer multifocal. So here I've cited a study that a clinical trial that compared multifocal contact lenses to monovision. And what I love about this study is they actually found the objective acuity was better with monovision. So the clinician was happy, but the patient subjectively preferred the multifocal, which is so interesting, from a clinical standpoint. It underlines how important it is to ask your patient kind of what their experience is. Multifocals provide better stereo acuity and range of clear near vision, which we know. But this study here that I cited shows that actually there's not that much different in things like contrast sensitivity with multifocals compared to monovision. In fact, this study concluded that multifocals give a better real world visual experience compared to monovision. And that's so important as clinicians to think about that, we shouldn't just get caught up in our our exam kind of charting of like, oh, did I get him to 2015? But you really want to think about the patient's real life experience with the lenses. So yeah, you're exactly right. I think multifocals are the way to go with this patient. Skip right over monovision, skip right over trying another single vision lens. So I'm going to pull out a fitting guide for this patient. We're going to fit this patient in. I'm going to use my clinical judgment and say we're going to fit this patient in the Acuvue Oasis One Day Max multifocal. And what's nice about J&J products is they all have the same sort of, they have the same multifocal optical design. So we can use the same fitting guide for any J&J multifocal product. So when I show you this fitting guide, what do you think? How does that make you feel?
I know right now I understand it a little bit better, but I will say, like, as a third year when I was first learning about this, like, this terrified me. I did not understand it. And there's so many parameters, I mean, they introduced, there's like center distance, center near, which eye do you choose for which one? There's concentric, there's aspheric, all the optics, like it's very intimidating, like learning this initially.
Super intimidating. Yeah.
Yeah.
Actually, I'm going to wait to talk about all those different designs with Dr.
Yeah.
Gromacki in a few minutes. But I like what you said, or I hear what you said about how the fitting guides can almost seem intimidating. I think it's great to remember that the fitting guides are there to like help you, right? They're there to hopefully make the fitting process as like foolproof as possible. So we can kind of look at this one together. So again, if I'm going to use the Oasis Max lens, basically what I need is this fitting guide, which is, I think is pretty succinct and, has nice little graphics, makes it pleasing to the eye and hopefully easy to read. And all I really need is my patient's manifest refraction and add power to know how to choose an initial lens for the patient. So we can see based on our patient's manifest refraction that their add power puts them in the sort of low add range for both their dominant and non-dominant eye. And that helps me pull an initial lens for the patient to at least get started with them. So, sometimes your decision on what multifocal lens you choose just comes with clinical experience. But if you're in the clinic and, you can find a fitting guide, that can help you sort of find maybe a fitting set that'll help that you can get started with the patient. So for this patient, we pulled these lenses and we're going to put them on her eyes and just kind of let them settle in for a few minutes. And then we're going to do a sort of real world visual assessment with the lenses. Again, we were talking about how we can sometimes be like type A perfectionists with our vision assessment. It's important to remember with multifocals, we kind of want less of a type A, right? I don't want to turn off all the lights and shine bright lights in them to assess their vision for a multifocal. I really want to assess vision with both eyes open in normal room illumination, using real world visual targets, trying to avoid the phoropter if possible, just using like loose lenses or flippers, and talking to the patient about what they can expect with adaptation with a multifocal. We expect our patients to have vision that improves as they adapt to the multifocal and as their brain kind of figures out how to find the sweet spot with the multifocal. So for this patient, she did really well initially with the lens. Again, we fitted her with those parameters in the Oasis Max 1-day multifocal and sent her home with the lenses, educated her, which is so important on what she might experience, maybe a little bit of blurry vision initially, maybe some glare and halos initially, maybe vision coming in and out a little bit as her brain learns how to adapt. But I also educate her that after she's adapted and comes in for that follow-up, I can refine vision more for her if necessary. What's really great about lenses on the market today, and especially a lens like the 1-day Max, is that most patients can, I'm kind of jumping ahead here. We'll jump ahead to this slide here. Most patients can have success with the first lens, which is awesome and totally debunks the myth that, multifocals are difficult to fit and hard to fit. So this particular patient came back for that 1-week follow-up with good distance and near vision, and reporting that those symptoms of eye strain that she had really decreased. So again, it really just speaks to the improvement in the technology that we have available to us, that most patients can have success with the first or second iteration of the lens. If you do have a complaint at that follow-up, that's what the fitting guide's for as well. So here's sort of a different flavor of the same fitting guide that's going to help us refine distance or near vision depending on what the patient's complaint is. So does that feel a little more comfortable, like looking at that now, kind of knowing how that works?
I think so. Yeah. Kind of going across the page, and it lays it out for you. You just have to look at it a little bit closer, like really understand what you're looking at, and then kind of move on from there. But just take time to understand the fitting guides, and it will come. It will come.
Yeah.
I promise.
It's just like take it one step at a time. Like don't move forward like to a complaint until you've got one, kind of thing.
Right.
So this would be a great time to pull Dr. Gromacki in, because I wanted to talk about I think she has really good insight on how to choose design types, how to choose a lens initially, how you even get started. She has just a wealth of experience and thoughts in that area. So Dr. Gromacki, what do you think?
Yeah, thanks for bringing me in. Let me start with a couple of things that I learned back in optometry school that were kind of unique, and they sort of kind of set me on my path to fitting multifocals all these years. And maybe you've already said this, Dr. Rueff, maybe you haven't tonight, but I remember a professor saying to us, would you ever put monovision in glasses? And I sat there and went, of course not. That's ridiculous. Why would we ever do that? Well, then don't do it in contact lenses. And so that was number one. And then the second thing you've already mentioned, which is so critical to success, because there are hundreds of lens designs out there. Soft, rigid, we've got lined bifocals, we've got aspheric. As Dana mentioned, there's a lot of different designs. So the key to success is following the fit guide, because every one of these companies puts together a fit guide to help us succeed. They have fit tens of thousands of patients. They know just how to tweak the lenses to gain success. We may have fit a couple hundred, Dr. Rueff and I. Maybe if you're in optometry school, maybe you haven't even fit any yet. So you need to trust the industry and trust the companies that are coming up with these designs, because they really know their in and outs, and they know exactly how to tweak it to get it just right. And one thing I do with the fit guide that Dr. Rueff showed is I actually use the troubleshooting guide on the very first visit if I need to. I don't wait until the follow-up, because I want them to have their best lens for their trial at home. And then hopefully the follow-up will be pretty smooth, minimal tweaks at all. As Dr. Rueff said, most of the latest technologies, you can get it right on the first day. You're not going to need to do a lot of tweaking at the follow-up. But if you do, that's why we charge higher fit fees for multifocals. We have to, because they are more complicated to fit.
Oh, those are all like really good points. I love would you put monovision in glasses? Like, absolutely not. Like, I would feel like I was doing something illegal if I did that, right? And sent my patient out to drive or something with monovision in their glasses. That's such a great analogy. Yeah, those are all really good points. How do you decide, Dr. Gromacki? So the lens that we chose for this patient is a center near lens. And Dana was talking about like, oh my gosh, there's so many designs and, setups, and how do I choose? Like, what's sort of your strategy for that?
Right. So first of all, I would recommend that now or when you get into practice, you really just stick with, say, 4 of your favorites, and you learn them inside and out and almost kind of get into head of the optics of that multifocal so that you know how to troubleshoot it better. So you know what your patient is going through. Because most of you, obviously, when you graduate, you're not going to be presbyopes yet. I've tried all these lenses now, so I can tell you how they are from a patient perspective, but it's really hard to do that if you're not a presbyope yet. So get a few lenses and really understand the fit guide and how that particular company is trying to help you succeed. So the first thing you obviously need to know is when you're putting a trial lens on there, what is the design of that trial lens? Is it a center near? Is it a center distance? Is it aspheric or concentric? Most people these days, even my 80-year-old mom, are on the computer. So we really benefit from fitting an aspheric lens. That's why the flat top, gas permeable, segmented lenses, one reason why they're not fit a whole lot these days, because it's really tricky to get that intermediate. Even if there is a third segment, like a trifocal, it's tough to get into that segment. It's much easier for the patient to use an aspheric lens because you have all the different distances and space right in there. So I like aspheric lenses for that reason, because everybody's always on the computer. Secondly, when I was in optometry school, I always was like, how in the world can a patient see distance out of a center near lens with the top amount of plus right in front of the optic center? But the pupil does all the work, and that's the important thing to know about a lot of these designs, is the success is predicated on pupil size. So you have to choose your patients wisely up front. Make sure that their pupils aren't too large, because if they are, they'll never utilize the center part of that lens. Make sure their pupils aren't too small, because if they are, they'll never utilize the mid-periphery of that lens. And for that reason, for older patients, center near work better at near, period, because as we get older, our pupil constricts. Also think about this. As we look at something up close, our pupil physiologically constricts. So that's why the center near always work better at near. It's because we're sort of blocking out all the mid-peripheral optics, the distance optics, the intermediate, and kind of honing in on the near. So for advancing presbyopes, I would say moderate and up, the center near is really going to be your choice. And if you opened up a Tyler's Quarterly or a class in contact lens spectrum, you would see the vast majority of designs these days are actually center near. And the bottom line is, this is the truth. Companies want to sell lenses, so they're going to sell what works. And center distance are great. They work great for young presbyopes, maybe even for this patient with a +1, because her pupil size will be large enough to utilize the near optics, which are not in the center. Of course, for myopia management, you have to fit a center distance because you want to create that peripheral defocus. But this isn't what we're doing here. We're trying to help people see better at near. So lately, I just start with a center near design. It's just less chair time for me personally. Not that the center distances aren't great for younger patients. They can be, but for me, when the patient actually needs that center near as they become sort of moderate presbyope, I don't want to have to refit them. I want to just be able to bump them up to the next ad and let that go. So for me, I fit center near, I wear center near, and that's kind of where I personally start. And so the newest lens on the market is the Acuvue Oasis Max 1 Day, and that is a center near. And there are some really great features in this lens that no other multifocal contact lens on the market has. First of all, I alluded to pupil size. I more than alluded to it. A lot of the lenses, again, that's their success, is you have to choose the patients wisely, make sure the pupil size is going to be sort of in a moderate range, not too small, not too big. once you know that the patient can access the different prescriptions in that lens, that's great. Now, looking at all the different lenses on the market, most of the soft lens manufacturers have only 2 or 3 ad sizes or optic zone sizes, or you could call it pupil size. It's not really exactly the pupil size, but it's sort of their near zone for the center near. And the reason why is everyone knows that as we get older, our pupils get smaller. So if a company has 3 different ads out there, let's say, they tend to have 3 different optic zone or pupil sizes. Here's a trivia question. I don't know if Dana knows this. How many different pupil sizes do you think the AccuView Oasis Max 1 Day has? It's okay if you're wrong, because I asked this to practicing ODs and you get answers all over the place.
Say like 200.
Wow, you're almost perfect. Right on.
She's almost exactly there.
Actually, I asked that question a lot, and you have come the closest.
Woo-hoo.
The answer is Johnson & Johnson has 183 different pupil sizes for their multifocals, because each lens in your trial set has a different pupil size, because they not only base it on age or ad like all the other companies do, they also base it on refractive error. So every single prescription that's in that set has a different optic zone or pupil size, because what J&J does is they also realize that myopes have larger pupils than hyperopes. So they factor that in. So it matches the pupil size better with the optics of that contact lens, and hence it enhances success. So they really help us satisfy every single patient based on pupil size. The other thing that's new with this Max 1 Day, because there's other 1 day lenses out there by AccuView. There's 1 Day Moist, and then they also have the 2-week Oasis. And as Dr. Rueff said, what's great about this family is you can move a patient from one of those lenses to the next, and you don't have to change power or prescription. You don't even have to over-refract. It's a seamless transition because it's the exact same multifocal design in all 3. So what they have, though, in the Max, in addition to the pupil optimized design, is now they have an OptiBlue light filter. So this is the only lens on the market with this. So what this lens does is it filters out visible light, blue and violet. And studies have shown that these are the wavelengths that create scatter within the eyeball. And we know this for low vision. We fit, low vision patients with no IRs, with yellow lenses, orange lenses. And we're doing a lot of this in spectacles now. And this is the very first contact lens on the market. It's also available in their Sphere 1 Day Oasis called Max 2. Max as well, not 2. And so this is really beneficial for your older patients, because light scatter has been shown to double by the age of 60, mostly due to changes within the lens, cataracts, but also due to dry eye, changes in the retina, lots of other things that happen as people age. So if you have people in their 50s and 60s and they've worn contact lenses their whole lives, they want to stay in contact lenses, and their vision just isn't as crisp as it used to be, this is a great lens for them, because if you block out all that aberrant light, you're going to maximize vision, which is especially important in multifocal designs. And then the last thing that's brand new with this lens on the market is that, unlike any other lens in the market, which is cured in one direction, when it's cured, it's polymerized. It's basically made into the final lens form that it's going to be. J&J built a brand new line. If you ever get a chance to visit J&J, please do, or any of the companies. It's amazing to see how these lenses are produced. It's just really, really fun. And this is a whole new line. It's not made on any other line of any other lens. It's its own special line. And actually, this lens is cured from both directions. So what does that mean exactly? It means that when you cure in both directions, you get a more even mix of the wetting agent, the PVP, within that lens. And when you can mix that wetting agent in better with the polymers, it does a couple things. One is it prevents the lens from drying out. So it increases wettability. And two, when you have a more even mix of that wetting agent, you can actually enhance vision. So these new technologies have been amazing for my patients, both in the multifocal and even in the sphere for the younger patients who you don't realize they have scatter going on due to some aberrant light rays, but they too have really enjoyed the Max, and mostly because they've noticed it's more comfortable. So this has been a really great addition to our toolbox, and it's a very recent addition. This lens literally just launched in September, so this is like brand new technology.
I love all the detail you had about this new lens, and I think that speaks to how we can't kind of lump multifocals into one category, right? Like just within this lens, there are so many features that, J&J has been really thoughtful about, who they're serving with this lens and how to sort of maximize their experience. And most multifocals are like that. There's thought and thoughtfulness put behind how to be successful. Like Susan said, the manufacturers want to sell the lenses, right? So this Max lens is really cool. That Opti blue light filter is really interesting to me because I don't know, I feel like my Instagram feed has been filled with blue light blocking glasses and stuff, and what they can and can't do. And I like that the purpose of the blue light filter here is really to amplify vision, basically, right? Like cut out the noise and improve vision and therefore improve sort of our visual comfort. So that was a really great description. Thanks for going over all those points with us. Dana, I don't know. What are your thoughts? Do you feel like a little less daunted by choosing multifocal or getting started with one? Or
I mean, yeah, I think this is a great discussion on multifocals, understanding your fitting guides. And honestly, this lens has me very excited. The pupil optimized design is what really stood out to me with this. Because from a physiological standpoint, it just makes sense to take that into account when you're designing a lens. And I think it's really awesome that they incorporated that into this new lens design. So that makes me very hopeful. And just the results from fitting so far, I've heard great things. So I'm excited to start fitting this lens, honestly, and to get started with more multifocals.
Yeah. Start with multifocals early and often. I feel like my multifocal patients are some of my happiest patients because I feel like oftentimes you're just serving a population that maybe has sort of been ignored or maybe underserved. And multifocals are fun and easy. And I love it when patients come in and say, oh, I didn't need readers, or I'm so much more comfortable at work, or all the other things that can benefit your lifestyle from a multifocal. So Dr. Gromacki, do you have any other thoughts or points or anything before we pull Darryl back in?
The only other thing that I would say is always start with a brand new refraction, because if you use the refraction from a year ago or even 6 months ago, it could be different. And you want that wow factor. You want the success to be with that first lens. And if you're even off by a quarter diopter, it could make or break success with multifocals. I think we're not here to say that they're perfect. They're absolutely not perfect, but they're better than ever. And if we follow the fit guide, we should be successful.
Yeah, and this patient's a great point or example of that, right? We found less minus in her prescription this year. And so, going with an old prescription, we would have started in the wrong place. So really good points. Great. Well, hopefully this helps all of you guys out there too who are listening. If you guys have any questions, you can always put them on the chat. Where's Darryl? Is he out there in the hovering out there in the universe?
I'm here. I'm back. Hey, all I can say is fantastic job. At the top of the show, I said there was a lot of brain power here, a lot of experts. I'm blown away. I was blessed to have this trial kit, one of the top, I guess, one of the first 50 or so in the country. And I tried this lens with several patients that I've had a challenge with fitting multifocals, and it has changed the way that I prescribe. I mean, this lens is truly the truth. And one thing that I love is that, we don't have to think that hard about this stuff. Follow the fit guide. I cannot stress that enough. Johnson & Johnson Vision has made it so easy for us that they actually have a QR code on the actual trial kit that you just use with it. Well, let me take a step back. I have an iPad that I see patients with my EHR system. So I literally take a picture of the QR code and it pulls up the fitting guide. I'm able to plug everything in And within a couple of seconds, I'm able to get back into that exam room, fit my patient. Majority of the time, they're successful on the first shot, and it reduces my chair time. And for me, I have a pretty fast-paced practice. Chair time is everything for me. So I have to have clear lines of communications, and I have to be able to execute on the first shot. And I just love how they've been able to make it more efficient for me and more effective in the exam lane. So this lens is the real deal. If you have not fit it yet, please fit it, because it would change how you fit multifocal contact lens.
Awesome. That's really great feedback. Yeah, you're one of the first people. I remember you telling me early on, you're like, I got this lens. It's really good.
Yeah. Now we're getting it into our ordering, our system to be able to order. So patients are ordering left and right. The thing is, why I love this lens is, again, I have a lot of patients that have had gaps. They haven't been able to really, see as well as they want to. So when you can find a solution that enhances their lifestyle, as soon as they put it on, they can see. It doesn't matter what the cost of the lens is. It don't matter how long it takes to come in. These patients are signing up, they're lining up, and they want to learn more, and they're going out to tell their friends and colleagues as well. This has been a fantastic show. Thank you again. Everyone here has done a fantastic job. We had a lot of royalty on the call today, and I would love to have everyone back at some point in time. I would love for each and every one of you maybe just to leave some words of wisdom. Dana, we can start with you. Maybe you can leave something for your colleagues that are in school right now, something that's helped you excel as a student. And then I'd love for the other ODs on the call to maybe leave some words of wisdom when it comes to fitting contact lens, especially multifocal contact lens.
Yeah, I'd say pick the hard patients when you're in clinic. You have the faculty with you right now, and you won't have them going in. I mean, you'll have colleagues, but you won't have someone right there to help you out on the spot. I know, like, I'll be out in the world in a mere 6 months. And so picking the hard ones definitely makes you think, and it makes you make decisions early on. So get hungry and get in the clinic.
Love it.
Get hungry. I like that. I would kind of step off from that, like kind of going off that same idea is, don't be afraid to utilize new technology or try something new for your patients. I know I work with students every day, and sometimes they'll come in and say, oh, well, they're happy in what they're in. We're going to keep going with that. And I would encourage you to step outside of your comfort zone and try something new while you have lots of fitting sets available to you. And yeah, somebody, an expert working with you who can help kind of guide you through that. This is the time to kind of try stuff and maybe stumble and maybe make a mistake or two, but you have, someone working with you to kind of help pick you up and teach you how to move forward.
Love it. Dr. Gromacki, bring us home.
Yeah, so I will say after 29 years, you guys have chosen a great profession. How great is it every day to help people see better? There's nothing better than that.
Amen. Amen. I love it. Thanks everyone for tuning in. Before we leave, we're giving away gift cards, $100 Amazon gift cards. And this evening we have 3 winners. The 3 winners are Alec Compton, Vanessa Francisco, and Lydia Smith. You will receive an email from me. You will get that either today or first thing in the morning. But I want to thank everyone for tuning in this evening. I want to thank our partners over at Johnson & Johnson Vision. We really appreciate you putting this together. We really appreciate you understanding the gap that's out there. And we really appreciate you being leaders and innovators in eye care. At the end of the day, we are all here to help patients see better. We're helping them with the most precious sense known to mankind, and that's sight. And we have to have the right tools and resources, and most importantly, the right partners to allow us to be able to give those patients what they need. So thanks so much for tuning in with us. We look forward to seeing everyone next time. We're going to have another lineup in December, so be sure to tune in. It's your favorite optometrist, Dr. Darryl Glover. Stay healthy, stay positive, and stay blessed. And until next time, peace. All right, colleagues, and it's a wrap. Thank you dearly for hanging out with the Defocus Media team. We hope truly something resonated with you. And if it did, be sure to give us 5 stars. And make sure you follow us on all social media platforms. Facebook, Instagram, Twitter, LinkedIn, you named it. And our handle is at Defocus Media on all platforms. And until next time, be sure to keep it 2020. And we look forward to seeing you on the next episode.